Welcome, fellow knowledge seekers, to the deep dive.
Glad to be here.
Today, we're plunging into a topic that touches millions of lives: cardiovascular drugs.
It really does.
They've got this comprehensive reference guide right here.
Yeah.
Let's try to cut through the really dense details, help you understand not just what these meds do, but why the specifics, the little things, truly matter.
Exactly. It's about understanding the why. We're digging into critical distinctions and definitely crucial counseling points for heart and blood vessel conditions.
Think of us as your guides, trying to grasp the core ideas behind these powerful therapies.
Not just memorizing names and doses.
Okay, let's unpack this then, get a clearer picture. Starting with a really fundamental system for managing blood pressure and protecting organs.
We're talking about the renin-angiotensin system,
Yeah.
RS. Now, drugs targeting this system, like angiotensin-converting enzyme inhibitors, we call them ACE inhibitors usually.
ACE inhibitors, got it, like lisinopril.
Exactly. Lisinopril and allopril. These often share indications with another class, angiotensin receptor blockers, or ARBs,
ARBs.
like losartan or valsartan. You see both classes used as sort of the front line for hypertension, high blood pressure, and heart failure, even diabetic nephropathy.
Kidney protection.
Yes, kidney protection.
So lots of overlap in what they treat. But okay, here's where it gets interesting. They also share side effects.
Common ones are hyperkalemia, that's high potassium levels, and a potentially increased SCR, serum creatinine, which flags kidney issues, or just general renal dysfunction.
Right, kidney function.
And ACE inhibitors specifically add that well-known dry cough.
Yes, not dangerous, but annoying.
Can be very bothersome for some people.
What are the really key differences, or the critical warnings we absolutely need to flag?
That's a great question. A major counseling point, and this is for both ACEs and ARBs, is to avoid NSAIDs.
Like ibuprofen.
Because combining them really increases the risk of kidney problems, and you absolutely have to monitor potassium levels carefully.
Other drugs that raise potassium are
Well,
involved.
actually, like potassium-sparing diuretics, potassium supplements. You don't want potassium getting dangerously high.
Okay, balancing act. There's this unique player you mentioned, the ARNI.
Ah, yes. The angiotensin receptor neprilysin inhibitor, RRNI. The main one is Entresto. It's actually a combination drug, sacubitril and valsartan.
And that one's specifically for heart failure.
Yes, specifically heart failure. And here's a really, really critical safety detail. If you're switching someone from an ACE inhibitor to Entresto,
Okay.
you absolutely must have a 36-hour washout period.
Stop the ACE, wait a day and a half, then start Entresto.
Precisely.
Why is that so critical?
Significantly reduce the risk of angioedema. It can be life-threatening.
Okay, so that washout isn't just a suggestion.
No, absolutely not. It's a non-negotiable safety protocol.
Subtle differences, big implications.
Exactly.
All right, so we've looked at the pressure regulators. Let's pivot now to another fundamental approach.
Yeah.
Managing diuretics.
Oh.
The water pills.
Right, the body's fluid managers. And they come in different types, too, each with its own personality.
Personality, I like that.
You have thiazide-like diuretics, clothalidone is one, often preferred, actually, for hypertension over the very common hydrochlorothiazide, or HCTZ.
Why? Just works better.
Generally seen as a bit more potent and longer-lasting for blood pressure control, but both are used for hypertension, and they share side effects.
Okay, what are we talking about?
Things like hypokalemia, that's low potassium this time, hypercalcemia, high calcium, hyperuricemia, high uric acid, it can trigger gout, and photosensitivity.
Photosensitivity, so more prone to sunburn.
They also have some significant drug interactions. They can bump up lithium levels, which is tricky. They interact with other diuretics, NSAIDs again, and digoxin.
Okay, practical advice.
Definitely take them in the morning for both chlorthalidone and hydrochlorothiazide.
Good morning.
To avoid nocturia. Waking up multiple times at night to use the restroom, it really messes with sleep.
Okay, what other types?
Then there's the potassium-sparing diuretic, spironolactone.
Okay, sparing.
Exactly. So it's used for hypertension, also heart failure. But while it spares potassium, it can cause hyperkalemia, high potassium, just like the ACEs and ARBs.
Ah, okay.
Absolutely crucial, especially if used with ACEs, ARBs, or potassium supplements. And spironolactone has some unique side effects too. Gynecomastia, which is breast enlargement in men, and sometimes erectile dysfunction.
Okay, good to know.
The loop diuretics. Furosemide, brand name Lasix, is probably the most well-known.
Lasix.
Yeah.
Used a lot in hospitals, right?
Primarily for edema, that's the fluid retention, and heart failure. They're powerful.
Powerful means
Static hypotension, getting dizzy or lightheaded when you stand up, and they can cause broader electrolyte issues. Low sodium, chloride, potassium, magnesium, and calcium. They kind of flush everything out.
lots of electrolytes to track.
Indeed. And for patients whose kidneys aren't working well, renal impairment, they might need higher doses to actually get the fluid off.
Makes sense.
Yes, take it early in the day.
So the takeaway with diuretics,
Mm-hmm.
they're definitely not water pills.
Each type is different. Affects different electrolytes, needs careful timing, careful monitoring. It's a real fine-tuning act.
Constant adjustments.
Mm.
Okay, let's move on. How about drugs that directly influence the heart's rhythm, its pace, and how blood vessels expand or contract?
Right. Critical stuff for cardiovascular stability. Let's talk calcium channel blockers first, CCBs.
CCBs, okay.
A very common one is amlodipine, brand name Norvasc. Prescribed a lot for hypertension and also stable ischemic heart disease, that's chest pain or angina, from reduced blood flow.
Or VASC.
A really notable point about amlodipine is that it's generally considered safe for treating hypertension, even if someone also has heart failure.
Oh, interesting distinction.
Common ones are edema swelling, often in the ankles, and sometimes reflex tachycardia.
The heart speeds up because the blood pressure dropped.
Exactly. It's the body's compensatory reaction.
Okay. Now, you mentioned nuance earlier.
There is, and this is a critical warning, it's about nifedipine, sold as Procardia or Adalat.
Okay, what's the warning?
The immediate release formulation, the short-acting one.
Immediate release nifedipine. Got it.
It has been strongly linked to bad cardiovascular events. We're talking angina, heart attacks, even death.
Wow.
Mainly because it can cause that reflex tachycardia you mentioned, but also a very
So the takeaway.
immediate release nifedipine should absolutely not be used to treat hypertension, full stop. The extended release versions are different, but the IR form is a major no-go for high blood pressure.
Definitely a key aha moment there. Formulation matters.
Then you have other CCBs like diltiazem, cardizem, and verapamil, Kalen.
Okay,
These are used for both hypertension and arrhythmias, irregular heartbeats.
so side effects might include a slow heart rate.
Yes, bradycardia is a potential side effect. Constipation can be quite common, especially with verapamil.
And interactions.
Yes, critical interactions. Diltiazem and verapamil significantly interact with beta blockers, amiodarone, and digoxin. They can really increase the levels of those other drugs.
Meaning,
Very important.
okay, let's talk beta blockers next then. Etoprolol.
Carvedilol, propranolol, a big class used for a whole range of things. Stable ischemic heart disease, arrhythmias, hypertension, heart failure. Really versatile.
Common side effects.
Fatigue is common. Dizziness, too.
Now, is there a big safety message with beta blockers?
There is, but it's about stopping them.
Okay, what is it?
Abrupt withdrawal. Just suddenly stopping them can lead to serious clinical deterioration. It can manifest as acute tachycardia, a really fast heart rate, a dangerous spike in blood pressure, and or ischemia that reduce blood flow to the heart.
So you can't just stop taking them.
Absolutely not. It needs to be tapered off gradually under a doctor's guidance.
Wow. Stopping is as critical as starting. Any specifics within the beta blocker class?
Metoprolol succinate, that's Toprol XL, the long-acting one used for heart failure and arrhythmias.
Yes.
Even though it's extended release, the tablets are actually scored, so you can cut them in half if a smaller dose adjustment is needed. Not all long-acting pills can be split.
Oh, that's useful to know.
And then drugs like carvedilol and propranolol, Inderal, they need to be used very cautiously or sometimes avoided altogether in people with asthma or COPD.
Because they can affect the airways.
Exactly. They can worsen breathing problems.
Okay, so CCBs, beta blockers, essential tools, but different mechanisms, different warnings, different interactions.
Working on the same complex machine, different tools, different risks.
Great analogy. Okay, let's round out the blood pressure discussion and touch on some chest pain protocols too.
Sounds good. Looking at some other antihypertensives, there's clonidine, catapres. It works centrally in the brain,
Okay, side effects.
known for causing dry mouth, sedation or drowsiness, and constipation.
And the key counseling point, is it like the beta blockers?
Avoid sudden discontinuation. Rebound hypertension, that dangerous blood pressure spike, can happen if you stop it abruptly.
Rebound hypertension.
Yes, terazosin, Hytrin. It's an alpha-1 blocker used for hypertension but also for BPH, enlarged prostate. Same risk of rebound hypertension if stopped suddenly.
I've heard that one can make you dizzy.
Yes, dizziness and orthostatic hypotension are common, especially when starting it. That's why it's often advised to take the first dose at bedtime to minimize those effects.
Take it at night. Sleep through the worst of the dizziness. Makes sense. Now, you mentioned something fascinating earlier about specific efficacy in certain groups. Hydralazine and isosorbide mononitrate.
Ah, yes. This is really interesting. Hydralazine is a vasodilator, widens blood vessels. Isosorbide mononitrate is a nitrate, also helps relax vessels when used together for heart failure.
Yes.
The proof that it works well has really only been established in African American patients.
Only in African American patients.
Primarily, yes. And even then, only after the patient is already on optimal doses of an ACE inhibitor or an ARB or an ARNI and a beta blocker.
So it's an add-on therapy for a specific group once other foundational meds are maxed out.
Exactly. The efficacy hasn't been proven with just hydralazine alone or just isosorbide mononitrate alone for this purpose.
Wow. That is incredibly specific.
It really does. And speaking of nitrates like isosorbide mononitrate, whether it's that combo or just long-acting nitrates for angina, there's another crucial protocol. You need a daily nitrate-free interval, usually about 10 to 12 hours.
A break from the drug every day.
To prevent tolerance? If you have nitrates in your system, the body gets used to them and they stop working as well, you lose effectiveness.
Ah,
Precisely. Keeps the vessels responsive.
okay. And what about the short-acting stuff? Nitroglycerin under the tongue, nitrostat.
For acute angina, stable ischemic heart disease, the advice there is very specific too.
Like what?
Keep it close by. You never know when you'll need it.
Makes sense.
When you take it, remain seated. It can drop your blood pressure quickly and make you faint.
Okay, sit down first. What if it doesn't work?
If the first dose doesn't relieve the chest pain within about 5 minutes, call 911 immediately.
Okay, don't delay. Do they expire?
They do, and they lose potency, typically. Keep them in their original glass container.
6 months.
The spray lasts longer, usually about 3 years, but always check the expiration date.
So again, protocols matter. Demographics, timing, nitrate storage.
Absolutely. These details are integral to the medication working safely and effectively.
Such a powerful reminder.
Oh,
Let's shift gears again. Moving into preventing clots and managing irregular heart rhythms, where precision feels paramount, stakes seem incredibly high.
they really are. Let's start with anticoagulants blood thinners. Warfarin, brand name Coumadin, is the classic one.
Warfarin. Been around a long time. How does it work?
It's a vitamin K antagonist. It interferes with how your body uses vitamin K to make clotting factors.
So less clotting.
Treating and preventing DVT and PE clots in the legs or lungs, antiphospholipid syndrome, and preventing strokes in people with atrial fibrillation, AFib.
Mean side effect is obviously
Bleeding.
bleeding and bruising. Yes,
Yeah.
that's the main risk you're balancing. And the crucial counseling point with warfarin is the need for regular therapeutic monitoring. The blood tests, PT-INR.
Exactly. You need frequent blood tests to measure how thin the blood is, aiming for a specific target range, usually an INR between 2 and 3 for most conditions.
And diet matters with warfarin, right?
Hugely important. Patients need consistent vitamin K intake. Not necessarily avoiding vitamin K foods like leafy greens, but keeping the amount they eat roughly the same day to day.
Does it need dose adjustment for kidney problems?
Generally, no. Warfarin doesn't require renal dose adjustment, which is actually quite different from many of the newer agents.
Let's talk about those newer ones then, the DOACs, direct oral anticoagulants.
Often seen as alternatives to warfarin, you've got the factor ASA inhibitors like apixaban, Eliquis, and rivaroxaban, Xarelto.
Eliquis, Xarelto, hear those advertised a lot.
And then there's a direct thrombin inhibitor,
Pradaxa.
Pradaxa. Okay. What are they used for? Similar to warfarin. Pretty much. DVT-PE, treatment and prevention, stroke prevention in AFib. And yes, the main risk is still bleeding and bruising.
But no routine blood tests like warfarin.
The main convenience factor. No regular INR checks, but they come with their own very specific instructions and complexities.
Okay, let's take apixaban.
Apixaban often requires specific dosing adjustments based on age, weight, and kidney function.
Okay, how about rivaroxabans? So
Rivaroxaban has a specific instruction. It must be taken with the largest meal of the day.
with food. Why?
For proper absorption. Taking it on an empty stomach significantly reduces how much drug gets into your system, making it less effective. And it should be avoided if kidney function is severely impaired.
What about dabigatran?
Dabigatran has unique storage requirements. It comes in a special bottle with a desiccant to keep out moisture, must be kept in that original container, and discarded 4 months after opening because it degrades.
4 months.
Yes. And its dosing is also heavily dependent on kidney function, with specific cutoffs and interactions to watch for.
So drug interactions are still a big deal with DOACs.
Oh, absolutely. A common thread for many DOACs is avoiding concurrent use with drugs that are strong PGP inhibitors or inducers. These can drastically change the DOAC levels in the body, either increasing bleeding risk or reducing effectiveness.
So the convenience of no blood tests comes with a trade-off. Meticulous attention to dosing, administration rules like taking with food, storage, and interactions.
Less testing, but maybe more need for precise patient understanding and adherence to these other details.
Okay, let's cover antiplatelets, aspirin, clopidogrel.
Right. Different from anticoagulants, they stop platelets from sticking together. Used for stable ischemic heart disease after heart attacks or strokes, TIA prevention.
Aspirin.
Key point. Simple one. It's not your go-to drug for a headache or general pain relief if you don't need its antiplatelet effect. Use other ASAIDs or acetaminophen for that, unless aspirin is specifically indicated for cardiovascular reasons.
Right. Don't use it casually for pain if you don't need to. Clopidogrel, Plavix, any key points?
Yes, a significant drug interaction. Certain heartburn medications, specifically the proton pump inhibitors esomeprazole, Nexium, and omeprazole, Prilosec, can reduce clopidogrel's effectiveness.
So if you're on Plavix, avoid those specific PPIs.
It's definitely something to discuss with your doctor or pharmacist.
Okay, last one for arrhythmias.
A very potent antiarrhythmic helps control irregular heart rhythms.
Potent often means significant side effects, right?
Amiodarone is definitely known for that. It has a wide range of potential serious side effects: pulmonary toxicity, lung damage; thyroid problems, both overactive and underactive; liver toxicity; even a strange slate blue skin discoloration with long-term use.
Wow, that's quite a list.
But maybe even more critically, from a day-to-day management perspective, are its drug interactions.
We mentioned it interacts with diltiazem and verapamil.
Yes, and it significantly increases the levels of other common critical drugs, namely warfarin, digoxin, and certain statins, specifically simvastatin and lovastatin.
Increases their level.
Can lead to warfarin toxicity, bleeding, digoxin toxicity, heart rhythm problems, nausea, etc., and increased risk of muscle problems from the statins.
So what's the practical implication if someone is already on, say, warfarin or digoxin, and they need to start amiodarone?
This is a crucial safety step. When starting amiodarone, you must proactively decrease the dose of digoxin and warfarin, usually by about 30 to 50%.
Cut the dose by a third right from the start.
Yes. To preemptively avoid the toxicity, it's a mandatory adjustment, non-negotiable for safety.
That really underscores the interconnectedness.
It's a perfect example of that.
Wow. Okay. What an incredible detailed journey through these cardiovascular medications. I mean, from blood pressure, fluid balance, heart rhythm, clots. It's crystal clear.
They come with very specific instructions, potential pitfalls we've discussed, and these really crucial interactions.
It's not simple stuff.
No. Understanding these details, whether it's that Entresto washout period, the consistency needed with warfarin and vitamin K, the warning about stopping beta blockers suddenly, or these major drug interactions like with amiodarone.
Personalized nature of it all.
Exactly. It's a careful balance, a fine-tuning act that needs real attention to detail, from the prescriber all the way to the person taking the medication.
So what does this all mean for you? It means medication management, especially for the heart, is intricate. You have to consider how many variables impact even a single drug's journey through your body. What does that mean for your own care or the care of someone you know?
It begs the question, doesn't it? What other daily habits might be subtly interacting with these life-saving therapies in ways we haven't even considered? Something to think about.